Thank you for having me. I'd like to start by acknowledging the traditional owners of the land, past and present, and thank you all for coming. You'll have to bear with me. I've not presented before, so I'm a little nervous. Oh, and I need my glasses. So, as I said, my name's Jenny Strike and I'm the Business Manager and Senior Practice Nurse at Go-To Health. I've worked in general practice since 2003 and plan to see out the remaining part of my career, the rest of my working career in this area. I commenced at Go-To Health in 2016. Okay, you have to tell me how to work this. There we go, sorry. Told you I was a novice. So I commenced working at Go-To Health in 2016, and at the time it was a multimodality clinic with a fledgling GP arm. We had approximately 120 patients at the time, 120 GP patients. Today, the general practice side of house services 1,350 patients. So there's been a remarkable growth in such a short time. The general practice side of house is currently growing by a rate of 25 new patients per week, and we need a new doctor. So if anybody knows one, please send them our way. We service a large cohort of ex-military personnel, with approximately 80% of our GP side of house is DVA patients, young contemporary veterans, with the general demographic being between 25 and 55 years of age. It's very different from most general practices. For example, we only have 10 diabetics, we have 8 heart disease, and we have 3 COPD. So the types of things that we're seeing in our practice is PTSD, anxiety and depression, adjustment disorder, and multiple musculoskeletal problems, and including lumbar, thoracic, and cervical spondylosis, osteoarthritis, and many, many joint injuries. So today's digger, who is the contemporary digger? Most of us think of this gentleman as our veterans. I'd like to challenge you to think of them as this, and this, and this, and this. But the bottom one, is who we mainly see. The vast majority of Go-To's veterans are aged between 25 and 55. If you think back to your own patient base, how many of you know how many contemporary veterans you have? Or do you too think of your veteran as that first gentleman with multiple chronic diseases or conditions? The contemporary veteran can present as a very proud ex-military man or woman that you see on Anzac Day. But the ones that we generally see in clinic are a very broken version of that. We need to start identifying our contemporary veterans in our clinics, as the care that they require differs very much from the norm. So I'd just like to talk briefly about Australia's military involvement since the Vietnam War. So as you can see, in Vietnam we were there from 1962 to 1975, and then we had a nice big break. So then we had Iraq in 1990 to 91, and Afghanistan from 2001 to today. Iraq again in 2003 to 2009, and we've had peacekeeping forces continually since 1947. So we have a large number of men and women who are actively involved in active service in very untravelled times. So Australia has had military personnel in Afghanistan for the past 18 years, and this is the longest wartime involvement that we've had in our history. Some of our veterans have been deployed 3 or more times, and some of them are under the age of 27 and had this level of involvement. Warfare has changed, and these men and women have often witnessed inhumane occurrences that are very hard to deal with. We can expect the number of our contemporary veterans to rise. The area that we are in Queensland, we service the Enoggera barracks, and their barracks alone medically discharge 700 defence members every year. 700 medical discharges, and that's from one barracks. We need to recognise how many people we have in our community that are suffering. And that's what they look like in Afghanistan. So I just wanted to have a quick look at the accepted conditions for veterans. These are the conditions that are from the most recent periods, so including Timor, South Sea Island, Afghanistan and Iraq. When we look at the top 20 list of accepted conditions for veterans who served in these places, we note that tinnitus and hearing loss are close to the top. Who would have thought you'd have tinnitus or hearing loss when you spend your life shooting a gun? Number 2 is PTSD, accounting for 10% of all claims. I'd like to challenge you to think that even though the number is 10%, I suggest it's way more than that. 10% is those that the military accepts or DVA accepts as their liability. There is now with the non-liability white card mental health, everyone can access care, but it doesn't mean that they're accounted for in these numbers. And with PenCat not able to withdraw those PTSD numbers, we're unable to get the real numbers of how many people there are, or what percentage of our patients have PTSD. As we look down the list and see multiple musculoskeletal conditions and problems and mental health issues, but there's no diabetes, there's no heart disease, and there's no COPD. If we compare that to the same list of accepted conditions for our Vietnam vets, we can see that hearing loss and tinnitus are right there as well. And interestingly, PTSD also accounts for 10% of the claims. Musculoskeletal and mental health issues remain prevalent. However, the difference is the addition of ischemic heart disease, chronic bronchitis and emphysema, malignant neoplasm of the prostate, and diabetes. So you can see that this generation is suffering from multiple chronic diseases as well. The hospitalization history reflects the same. So in this one, we're looking at 18 to 54-year-olds, ex-servicemen, and again, you can see that there's anxiety, back pain, upper respiratory conditions, alcohol use disorders, and down the line, there's no chronic illness. But if we move to, did that change? Yep. If we move to the next one, which is for those aged 55 and over, then we start to see the introduction of those chronic diseases. So our aim at GoTo is to prevent these young men and women from developing these chronic illnesses. All this information that I've have so far is out of the profile of Australian veteran, which can be found on the DVA website. Mental health and suicide risk. It's one of our biggest problems at GoTo. We have a lot of people on suicide watch all the time. So as you can see there, during the entire Afghanistan conflict, 41 members of the Australian Defence Force have been tragically killed in action. But between 2001 and 2016, there were 373 suicides among service reserve and former members of the Defence Force. That's nearly tenfold. In this those numbers are extremely exaggerated since then. We've lost a lot more in the last 2 years. In 2015, the Mental Health and Transition Study found that more than 1 in 5 recently transitioned ADF member reports suicidal ideation, plans or attempts in the last 12 months. 29% felt that their life was not worth living. 21% felt so low that they thought about death by suicide. 8% had made a suicide plan, and 2% had actually attempted suicide. So managing mental health issues and the risk of suicide is ever present. To date, we have the 2015 Mental Health and Wellbeing Transition Study also measured the prevalence of mental health disorders among ADF personnel who discharged between 2010 and 2014. The most common classes of lifetime mental disorders were alcohol disorders and anxiety disorders. 48% for alcohol disorders and 46% for anxiety disorder. Compared with current serving ADF members, the study also found consistently higher rates of self-reported mental health symptoms among recently transitioned personnel, including high to very high levels of psychological stress, 33% compared to 19%, high to very high post-traumatic stress symptoms, 24% compared to 9%, moderately severe to severe depressive symptoms, 20% of recently transitional personnel compared to 7% of serving, and moderate to severe general anxiety disorder symptoms, 22% to 10%. Transitioning members struggle with returning to civilian life, especially if their discharge has been non-voluntary or medical discharge. For many, they have joined the ADF as their first job and become overwhelmed with the loss of career, their sense of belonging, and their true identity. So who are we and what do we do? So we're a multimodality clinic with 37 members of our team, all under the same roof. We include general practice, nursing, physiotherapy, exercise physiology, psychology, acupuncture and Chinese medicine, remedial massage, naturopathy, clinical Pilates reformers, physiotherapy group exercise, and an awesome admin team. They made me put that in there. A collaborative, integrated approach to healthcare that actually works. What's so great about working in a multimodality clinic is there's no siloed practice, and we talked about that earlier in some of the other presentations. Our clinicians talk to each other on the day about people they're treating. It's not uncommon for our patients to be seeing the GP, the nurse, the physio, the psychologist, and the exercise physiologist, and possibly the dietitian on the same day. We feel that if we do that, if they have 1 day of treatment, means that they can be demedicalised and have 4 days with no appointments. They struggle with being demedicalised because they like somebody, they're from the military, they like to be told what to do, where to go, and how to do it. So our model is to work together to get best outcomes for them. So if we're not actually getting results, if the physio's not getting results, we say, why aren't we getting results? Why aren't they improving? So they talk to the exercise physiologist and together they work out a plan. Or they get the acupuncturist in to say, their anxiety is so high, I can't actually get them to relax. So the acupuncturist may put some needles in while they're having treatment, or the acupuncturist may see them while they're seeing the psychologist, because their anxiety levels are so high that they can't actually take in their cognitive behavioural therapy. So it's all about working as a team. Our nurses are the pivotal point, the pivotal coordination point for them. Oh, wrong way, sorry. Okay, so what makes GoTo different and the gold standard for veteran care? Every new patient that comes to our clinic sees the nurse first for a 30-minute appointment. In that 30-minute appointment, they do a height, weight, a blood pressure, take their past medical history, make sure that their white card list of accepted conditions is added, and we do a post-ADF discharge health assessment, the nursing component. They then see the GP for a 30-minute appointment. In that time, the GP has all of that information available to him, and so he can start doctoring from the very first minute he has the consult. These patients are extremely complicated. As I said, I've been in general practice for the last 16 years, and these are the most broken, complicated people I've ever worked with. Whilst they don't have chronic illnesses, they certainly are chronically broken. So then, after they've had a post-ADF discharge health assessment, they've already developed that rapport with the nurse on their first visit. Shortly after that, once they've settled into the clinic, and if their conditions warrant it, they commence a GP management plan and team care arrangements, and this ensures a coordinated, cohesive approach to their care. Again, puts the nurse in the pivotal middle to be able to coordinate their care. If they're a CVC, if they're a gold card holder and an eligible gold card holder, they'll be put onto the coordinated veteran care program. But before we get there, just with our GP management plans, we have done a very structured and customised care plan templates that are relevant to these contemporary veterans, because they are very different. They come in with so many complex needs that very often the normal preventative medicine that you would do normally in your general practice gets missed. So our care plans ensure that all those boxes are ticked. So we look on the care plans, we look at their condition management, their mental health status, their pain management, family and social issues and influences, team players and their role in their care, weight and weight goals, dietary intake, alcohol and drug status, smoking status, exercise status, annual pathology screens, cervical screening, mammograms, skin checks, biomechanical assessments, bowel screening for over 50, BMDs for over 70s, and all members of the go-to team use our best practice software. Hence, all of the software, so all of the providers are able to have instantaneous notification of where the patient is up to. And that's Tracy, our coordinated veteran care nurse. So our coordinated veteran care program, as I said before, is for eligible gold card holders. It has a nurse CVC coordinator, and the program is customised to meet the needs of the contemporary veteran. We give them a green folder. It's bright green, and it's their visual reminder, engagement, and empowers them to take control of their own healthcare need. Inside that green folder, we put their entire medical history, and we update it every 90 days. The monthly CVC nurse coordinator phone check-ins, and the CVC is reviewed every 90 days. The whole aim of the program is to develop a trusting relationship with a CVC coordinator, with the aim that the veteran will pick up the phone and ask for help if the darkness comes, and the darkness comes regularly. So I commenced the CVC program at GoTo in 2016. It's been customised to meet the needs of our clientele. And as most of you will be aware, the CVC program is fashioned to service the needs of the older veteran and has the management for chronic disease focus. Our guys don't have chronic disease, but they do have complex care needs. Contemporary veterans need a different approach. The program we deliver aims to build that trusting relationship between the veteran, the CVC coordinator, and the GP. It's to engage and empower the veteran to be in control of their own healthcare outcomes, prevent hospitalisation, and preventative medicine to reduce the risk of chronic illnesses. It's coordinated care at its best, and it keeps the veteran safe. So CVC and GoTo Health is a collaborative, integrated approach to veteran care with the nurse as a pivotal coordinator of care, can achieve optimal patient outcomes. Despite the high risk of suicide indicative of this cohort, GoTo is really proud to claim that we've not lost a single veteran to suicide, although we've been very close. And that's all.
Anybody have any questions?
Yeah. Sure.
That's right, I can project. Just a query about the number of homeless veterans that you have. I don't think very many people know what proportion of ex-servicemen and women are actually homeless.
Yes, we're starting to see a larger number of homeless veterans. We have patients that travel to us as far north as Cairns, and we're in Brisbane, as far north as Cairns and central New South Wales, who will travel to us because they can't get veteran-friendly care. So we need, as nurses, we need to find who are these people in our cohort, because so many of them are homeless. We have about probably 15 to 20 homeless veterans, and they are actually now on the RSL radar. We have very good links with our RSL advocates and also with the base. So if they have concerns, they will actually put them in touch with us. Our problem right now is we're having catastrophic success. We have such growth. I have 2 GPs. One GP is ex-military himself and the owner of the practice. So hence the focus of the veteran clinics. And the other one is Dr. Ian Fraser from Townsville, has 40 years experience with DVA in Townsville. Neither of them work full time, but we're seeing, not just in general practice, but our clinic sees 700 patients per week. So we are now having 25 new patients per week in general practice. So the demand is there. We either need to share the love and everyone get on board and find out more about how to look after veterans. And your GPs need to learn how to do the paperwork. The problem is paperwork for DVA is massive. You must do a lot of paperwork.
I looked a while ago at the veterans research target because I was just seeing if it was a program in my practice, but I think the program, the funding stopped or something. Do you know where?
No, it's not. CVC?
Yeah.
No, it's not. It's not about to stop.
Presented at one of the NH ones I can still and the item not going to be
There's a booth in the break. There's a booth and the routine.
Yeah. They're just rolling out a white card CVC pilot. It's not going to stop.
No, I mean the training for it.
Oh, the training. Can I just say, if you're seeing contemporary veterans, that training isn't actually relevant to contemporary veterans. I started with doing the way the program is designed, and our patients, it wasn't relevant to our patients as young men. It's very relevant to older veterans.
They are reviewing it at the moment. They're in the process of reviewing it.
I think module 4 is still relevant, which is around social isolation and mental health and wellbeing, because that's relevant to everybody.
Yeah.
So,
Yeah. Yes.
So are you contracted by the military to handle ex-servicemen and women, or is that just you put yourselves out there as that?
We put ourselves out there. We are in Everton Park, which is very close to Enoggera Barracks. Dr. Kieran McCarthy is our owner, and he's ex-military. He's had 5 deployments himself. He knows the struggle. And so it was his interest through the general practice side of house. I've been with him for 3 years, and it's gradually built. We call it DiggerNet, Diggers Trust Diggers. So there's now a website on Facebook called DVA Entitlements, and if you have a look on that DVA Entitlements page, every time someone asks for a request for a DVA-friendly doctor, go-to comes up, and it comes up with 20 or 30 recommendations from other diggers. So it's just a self-licking ice cream now, which is great. It's great for business, and it's great that we can offer the services, but we need more doctors. So please, if anyone knows any doctors, please send them to me. Yeah. Yes.
I'm wanting to understand where the funding for the allied health care comes from. Is it all PVA funded, or is it NPCs and care plans?
It's At both. All our DVA patients, if their accepted condition is relevant to, like for instance, if they've got lumbar spondylosis, then obviously their physiotherapy and exercise physiology is covered under DVA. If they have a elbow injury for their list of accepted condition and they want to see the dietitian, then obviously we need to do an EPC funding for the dietitian. So the practice itself sees private patients as well. We have 10,000 active patients throughout the clinic. So it's not just DVA, but through our general practice side of house, it's 80% DVA patients. So just on that allied health sector, with the non-liability mental health funding for white card holders through DVA, they're entitled to see a psychologist to get mental health assistance. DVA pays 60% under normal rate. So therefore, it's really hard. There's whole clinics across the country that won't see DVA because they don't pay. They don't pay enough. They don't pay work cover rates. So it's really hard for us to hold on to good psychologists because they get 60% cut, a 40% cut in their pay. And allied health is we lose $20 a service session dealing with DVA for allied health. For physio, exercise physiology, I think is $23. So our clinic chooses to do veteran care because it's a passion of the people that are working there, but something needs to change or we're going to have a whole lot of damaged men and women that who only have access to poor quality services. So, yep. Yes. I'm really sorry, but we have spent a lot of time and money in developing it, and it's covered by our IP. I'm sorry, but yeah, it was hours, months of development, and it's worked on experience and the practice itself. We're working under our IP, so I'm sorry. Yep. Yep.
Thank you.
Thank you.